OCD is an anxiety disorder that's expressed by obsessing over thoughts or acting out thoughts as compulsions. In some cases, patients with OCD will have both obsessions and compulsions. But this goes further into signs and symptoms, which Abijah will later explain in the presentation. Onset of OCD is most common during young adulthood, but it can occur at any other stage throughout a person's life. The disease tends to progressively increase in symptoms and severity as a person ages, so if treatment is not sought out soon, the disease will only progress and get worse. OCD is often misdiagnosed as depression or anxiety. The exact etiology of OCD is unknown, but there are some risk factors and theories. There are 3 risk factors that I found. The first one is temperament, and this refers to personalities that are more prone to having OCD. There are 5 types of personalities: perfectionism, indecisiveness, impulsivity, responsibility, and neuroticism. The second risk factor is the environment a person grows up in. Stressful situations in a person's life can cause a person to feel unsafe. Types of stressful situations include physical, emotional, or sexual abuse. The third risk factor is genetics. If you have a relative who has OCD, your chances of getting OCD is increased. This could be caused by the actual genes in your DNA, or just the fact that you see this person and how they act day to day. Theories for etiology include brain function or structure abnormalities. One article talked about how people with OCD have decreased gray matter in some areas and increased gray matter in other areas where there shouldn't be. Another article suggested that certain areas of the brain in patients with OCD have decreased activity. Some areas include the prefrontal cortex, cerebellum, hippocampus, amygdala, and hypothalamus. Another theory for the etiology of OCD is neurotransmitter abnormalities. One important neurotransmitter is serotonin. It is thought that patients with OCD have an insufficient amount of serotonin. Serotonin is necessary for the movement of chemicals across the brain cells and neurons. So patients who have OCD may have insufficient serotonin and therefore have trouble processing their thoughts and doing actions. Another neurotransmitter abnormality may be an increased dopamine level. Dopamines are a pleasure seeker. People do things that cause their body to secrete dopamine, which increases our happiness. People who have OCD already have an increased amount of dopamine, which causes them to have to act out more compulsions in order to receive more dopamine and therefore pleasure. And it's just a cycle of increasing dopamine, increasing actions, increasing dopamine, increasing actions. Okay, so I have a quick fun question for everyone. Can you guess which Disney character in Winnie the Pooh is portrayed as having obsessive compulsive disorder?
So as discussed previously, obsessive compulsive disorder, or OCD, is an anxiety disorder which is exhibited through obsession and compulsive actions. And these are the symptoms. So OCD, they're obsessed through obsession and compulsion. Some patients only exhibit obsession and others compulsion, but most commonly these two correlate with one another and are exhibited together. Patients might not even realize that they have OCD until the obsession and compulsions become so excessive and so powerful and unreasonable that the patient spends a great deal of time on these, and they begin to interfere with activities of daily living, or ADLs. So the first component of OCD is obsession. It is the repeated and unwanted and persistent thoughts that cause the patient distress or anxiety. It's very interesting because obsession is the distress, and then compulsion is the act to relieve that stress. Common themes actually of obsession that patients may have can be fear of contamination, needing to keep things orderly and symmetrical. They might even have thoughts about harming themselves or other individuals. They might also have thoughts about sexual subjects, might lead to a sexual disorder. The other component is compulsive symptoms, and that is the repetitive behavior that patients feel driven to perform. So again, as mentioned before, obsession is the unwanted persistent thoughts that cause distress or anxiety. The compulsion or the behavior is the practice that they do to relieve themselves of it. The problem, though, is that the compulsion only gives temporary relief from anxiety or no pleasure at all. So because of that, they continue to repeat the compulsion and obsession. So just like obsessions, compulsions also have a common theme. This includes washing regularly, checking things very frequently, counting, keeping things orderly, demanding reassurance from themselves and other people, and then following a very strict routine. And all of this information can be found on Mayo Clinic. So OCD often begins with teenagers and young adults, and then progresses gradually, and then also worsens big time. Symptoms usually worsen as patients experience stress in their lives or difficult situations or very challenging circumstances. They're considered to be a long time or chronic disorder. Symptoms can range from very mild to very moderate, or can be severe enough that it becomes disabling. And this is the point that patients usually realize that I have OCD, when it becomes so disabling that they can't perform day-to-day activities of daily living.
Now treatments. The main line treatment for OCD is cognitive behavioral therapy. This can be approached in several ways, but the most common types for OCD are habit reversal training, or HRT, systemic desensitization, and exposure response prevention, or ERP. For HRT, the first step is awareness training. Here you help the patient become aware of the compulsion. This will allow them to ID the triggers and increase their control over the situation. Next, you teach them to substitute the response with another behavior. This is called competing response training. For example, you have OCD and your niche is pulling out your hair. I, as a therapist, would teach you to ball up your fists and lock your arms straight, so when you're experiencing this urge, this would prevent you from being able to touch your hair. Next, we have systemic desensitization. This is where I, as a therapist, would teach you to perform relaxation techniques. We all know square breathing. Breathe in, hold 1, 2, breathe out, hold 1, 2, right? Now, once I've gotten you in the most relaxed state, I would progressively expose you to the fear stimuli through guided imagery. I would slowly increase this into a real-life exposure of this triggering factor. The idea behind this is that you can't be relaxed and anxious at the same time. So once I've gotten you in that really deep, relaxed, almost meditative state, then the anxious response can't occur when I introduce the trigger. This will allow you to be around the stimuli enough times without the anxiety response and compulsion that you'll be able to stop the compulsion altogether when you're introduced to the trigger. Or in other words, you get desensitized. Lastly, the first line treatment for cognitive therapy is ERP, or exposure response prevention. If I'm the therapist and you're the patient, we would start out making a list of all the fears that you have and say that germs are one of the things you're anxious of, and your compulsion is you have to wash your hands afterwards. Of course, we would start this training out with using your lesser triggers, things that wouldn't induce such a high anxiety. So say germs isn't your biggest concern, but it is something that you're concerned about. So we would start out by making you touch the floor next to the garbage can. Now, instead of you doing your compulsion, which would be to wash your hands immediately, as you would do if you had OCD, we would wait a minute before going and washing your hands. And then maybe the next time we meet up, we would wait 2 minutes before washing our hands. And then the next time you would move on to touching your garbage can and waiting a minute. And then the next time we meet up, maybe 2 minutes. We will continue to increase this until you're able to touch the dumpster and no longer feel the compulsion to wash your hands immediately. You can see over on the bottom corner here, I have a little infograph with a ladder on it that tells you kind of what the steps would be to slowly weaning you up to touching the dumpster. Now, drugs. They have found with OCD the neurotransmitter abnormalities are really similar to those diagnosed with depression. So, the mainline treatments are going to be antidepressants. Clomipramine is a tricyclic antidepressant. This increases the effect of the serotonin and norepinephrine in the CNS. It was the first drug established for OCD and remains the first-line drug option when people are diagnosed. Other options are SSRIs, or selective serotonin reuptake inhibitors. We all know what that does. It pretty much says it in the name. Examples of this could be fluoxetine or Prozac, sertraline or Zoloft, and paroxetine or Paxil. I might not have said that right. Sorry, I wrote them all down multiple times so you guys know what I'm talking about. I've also provided a reminder that when working with people with OCD, we should be supportive and encouraging them throughout the treatment plan, and we should remain non-judgmental. We might find it ridiculous they can't touch the garbage can, but it's very real to them. So if you were listening, you'll be able to answer this. Which drug is the first-line treatment for OCD? Fluoxetine or Prozac, sertraline or Zoloft, clomipramine or Anafril, or ERP, exposure response prevention. Thank you.
Now I will discuss post-traumatic stress disorder. Post-traumatic stress disorder, or PTSD, is an anxiety disorder that impacts people from all walks of life, regardless of age, sex, ethnicity, or economic status. PTSD can be defined as a form of reaction to a significant trauma in someone's life that causes distress. It is also important to note that not every person who is exposed to trauma develops post-traumatic stress disorder, and that it's highly dependent on what the traumatic experience was, the individual themselves, and the environment the individual is in during recovery. To expand further on this idea, the traumatic experience itself can play a large role in whether or not a person develops PTSD. How long the person is exposed to the trauma, the amount of time they were able to prepare for the event, the amount of control they had over the situation, and even the location where the trauma occurred can all impact the severity of PTSD. The severity of PTSD is also impacted by the environment in which the person is able to get help, such as the role of support systems in their life and the beliefs and values of the culture they belong to. To expand further on this idea, for example, someone who grew up in a culture that highly stigmatizes post-traumatic stress disorder may be more likely to second-guess seeking treatment as they don't want to admit that they have a disorder, which can have numerous negative impacts on them later in life. Finally, and arguably most importantly, the individual themselves can impact their response to trauma. Their pre-built coping mechanisms, previous exposure to similar or the same trauma, their current stage in development, and current psychological state can all play a large role in how PTSD leaves a mark on their lives. The individual may experience this trauma alone or in the presence of others. As a nurse, it is important to understand the differences between PTSD and a similar disorder known as acute stress disorder. While both involve a traumatic event that triggered the symptoms, acute stress disorder only lasts for a month, whereas PTSD can last for much, much longer than a month. It is also important to note that symptoms the patient may show are not related to experiences such as uncomplicated bereavement, marital conflict, or chronic illness, but instead events that would be distressing to just about anyone. Something that is important to consider are the risk factors for developing PTSD. Some of the risk factors include exposure to actual or threatened death, serious injury, sexual violation, direct experiences with a traumatic event, witnessing a traumatic event in person, learning of a traumatic event that happened to a close family member, or experiencing firsthand extreme exposure to adverse details of a traumatic event through pictures, media, television, or movies. Other risk factors can include genetic factors, where somebody who has more of a chance of getting conditions such as schizophrenia, bipolar disorder, or major depressive disorder have a greater influence on developing PTSD. My question for you is, what is the difference between the two anxiety disorders, PTSD and acute stress disorder? Now, Lesley will talk about the symptoms of post-traumatic stress disorder.
So just to reiterate, post-traumatic stress disorder, or PTSD, is characterized as a reaction to an extreme trauma or exposure to an identifiable stressor which causes persistent distress that interferes with the person's ability to function. As per the DSM-5, to be diagnosed with having PTSD, symptoms must last longer than 1 month and may appear weeks, months, or even years after the event has occurred. Symptoms have to be severe enough that it interferes with functioning in relationships or work. There is this assumption that PTSD can only affect military veterans. The reality is PTSD can emerge at any age, and not everyone with PTSD has been through a dangerous experience. The National Institute of Mental Health states that for adults to be diagnosed, they must have all of the following symptoms for at least 1 month. The first is at least one re-experiencing symptom. The second is at least one avoidance symptom. The third is at least 2 arousal and reactivity symptoms. And the last is at least 2 cognition and mood symptoms. Re-experiencing symptoms may occur from the person's own thoughts, feelings, words, objects, or situations that are reminders of the trauma. That includes flashbacks, which is reliving the trauma over and over, including physical symptoms like a racing heart or sweating, bad dreams, or frightening thoughts. Avoidance symptoms are things or situations that remind a person of the traumatic event. So that includes staying away from places, events, or objects that are reminders of the experience, avoiding thoughts or feelings related to the traumatic event. Arousal and reactivity symptoms are usually constant instead of being triggered by something that brings back memories of the traumatic event, which are being easily startled, feeling tense or on edge, having difficulty sleeping, and or having angry outbursts. Cognition and mood symptoms include trouble remembering key features of the traumatic event, negative thoughts about oneself or the world, distorted feelings like guilt or blame, loss of interest in enjoyable activities. So again, to be diagnosed with PTSD, a person must have at least one re-experiencing symptom, at least one avoidance symptom, at least 2 arousal and reactivity symptoms, at least 2 cognition and mood symptoms. All have to be present for at least 1 month, but these aren't the only symptoms that can occur in a person. Others include a fight or flight response due to the feeling of fear during and after the trauma, continuous stress or being frightened when they are no longer in danger, anxiety, nightmares, negative emotions, inability to remember certain aspects of the trauma, depression, aggressive or reckless behavior, and problems with personal relationships. And just a reminder that not everyone who lives through a dangerous event develops PTSD. Most people will recover quickly without intervention. These symptoms I just listed are usually seen in adults and in some teens. Teens usually show disruptive, disrespectful behaviors or even feel extreme guilt like it was their fault. In young children, symptoms can include bedwetting, forgetting how to talk or being unable to talk, acting out the event they experienced when they play, and clinging on to their parents or another adult. There are so many assumptions and a stigma around PTSD that most people won't even tell their loved ones they are having issues. They are in fear of being labeled and often struggle since they are misunderstood. Everyone experiences trauma differently, and because people don't show these exact symptoms listed doesn't mean they don't have it. People can live a normal life while coping with PTSD. PTSD also can't be cured, but it can be treated.
For the treatment of PTSD, one option includes cognitive therapy. This therapy can help the patient modifying their thoughts and beliefs that they have associated with the trauma that they have experienced. The goal behind this therapy is to help the patient regain the ability to be hopeful and believe in a future that includes them feeling safe, regaining power, control, and a better self-esteem. This involves confronting any inaccurate notions and/or negative thoughts related to their traumatic event and replacing those with more accurate conceptions. In addition, it helps to confront feelings the patient may have, such as anger, guilt, and fear. Another therapy option is prolonged exposure therapy. This involves exposing the patient to their traumatic experience through an imagined or real in vivo situation. Vivo means that the patient is faced directly with situations and/or stimulus that provokes anxiety and is often what they avoid and/or escape from as it relates to their trauma. This helps the patient to perceive the event in order to neutralize their memories through a prolonged exposure and repeated exposure by the imagined or real in vivo situations. The goal of this therapy is to prevent the patient from continuing to resort to escape or avoidance behaviors when presented with thoughts, feelings, memories, or any other stimuli related to their experience. Group and family therapy is another option. This allows the patient to be able to share and discuss their experiences in social adaptation. It has been found to be especially effective for those who are military veterans with PTSD, since it allows an opportunity to talk about the experiences and stressors they have with other empathetic fellow veterans. Additionally, this provides an opportunity for patients with PTSD to discuss options on how to manage aggression towards others or any other symptoms they may have. Eye movement desensitization and reprocessing therapy, otherwise known as EMDR therapy, can also treat PTSD, with efforts behind this therapy being that they want the patient to process their emotions, which means the patient will have experiences and thoughts digested and stored properly in their brain, which is done through the patient focusing on their feelings related to their event while focusing on the rapid eye movements that they perform in therapy. Based on research, it has been indicated that these rapid eye movements help in decreasing the clarity of the experience image-wise, but also increase memory access associated with the event. Lastly, pharmacotherapy is another option. This includes medications like antidepressants such as SSRIs, which are a first-line treatment for those suffering with PTSD. Other antidepressants that have been used include tricyclics, amitriptyline, imipramine, MAO inhibitors, and trazodone. Another group of medications are anxiolytics, like alprazolam and benzodiazepines. These are effective in treating PTSD since they provide an antidepressant and anti-panic effect. Another group of medications are antihypertensives. This includes beta blockers like propranolol and alpha-2 receptor agonists like clonidine. These are effective since they help to reduce symptoms seen in PTSD, such as nightmares, intrusive recollections, hypervigilance, insomnia, startle responses, and angry outbursts. Another option of medications are carbamazepine, valproic acid, and lithium carbonate. These medications also reduce symptoms seen in PTSD, more specifically intrusive recollections, flashbacks, nightmares, impulsivity, irritability, and violent behavior. And for the question regarding the treatment of PTSD, the question is, what is the goal of prolonged exposure therapy for treating patients with PTSD? Option A is to help the patient regain the ability to be hopeful and believe in a future that includes them feeling safe, regaining power and control. B, to prevent the patient from continuing to resort to avoidance and escape behaviors. C, to share and discuss their experiences in social adaptation. Or D, to perform rapid eye movements.
Acute stress disorder is characterized by persistent, unrealistic, and excessive anxiety and worry that have occurred more days than not for at least 6 months and cannot be attributed to
specific organic factors like caffeine intoxication, hyperthyroidism. And then for etiology, psychodynamic theory focuses on one's inability of the ego to intervene when conflicts occur between the id and the superego, which then results in increased anxiety. This may be caused by unsatisfactory parent-child relationship, conditional love, or provisional gratification. Cognitive theory, anxiety is caused by one's loss of ability to reason regarding the problem or from distorted thinking patterns. So if someone is unable to problem solve, it leaves them feeling defeated and vulnerable, kind of feel like they're stuck, which then also increases the anxiety. Genetic factors contribute to your predisposition to the disorder. So if you have family history of anxiety, you may be at more risk from getting anxiety disorder as well. Neuroanatomical causes are often from dysfunctions in the limbic system or the frontal lobe, which all of the thinking happens, related to the psychodynamic and the cognitive theory. And another neuroanatomical causes are from anatomical abnormalities in the hippocampus and our amygdala, which is all the emotion sensitive parts of the brain. Biochemical causes are due to abnormal elevation of blood lactate. So increase in lactate causes panic attack-like symptoms, which then causes the person to feel more anxiety. So people with this anxiety are also most likely to have panic attack disorders. And neurochemical causes are often from abnormal regulation of norepinephrine, which is the fight or flight symptoms. So, in contrary, increase in serotonin would help them to reduce the manifestations of their anxiety.
In acute stress disorders, patients may present with 14 symptoms across 5 different categories. One category is intrusion symptoms. Intrusion symptoms include involuntary thoughts, memories, dreams, or flashbacks relating to the traumatic event. The next category is negative mood, which is characterized by the persistent inability to experience positive emotions. Patients with ASD also may have dissociative symptoms. This includes the inability to remember an important part of the traumatic event or even an altered sense of reality. The next category is avoidance symptoms. This may be manifested by avoidance of external reminders or distressing memories of the traumatic event. Arousal symptoms include sleep disturbances, an exaggerated startle response. They may present as irritable or have angry outbursts. The patient may be hypervigilant or have problems concentrating. Question: how many symptoms at least must a person manifest to be considered with the diagnosis of ASD, acute stress disorder? A, 5, B, 9, C, 14, D, 12.
The pharmacological treatments for acute stress disorder, first one is SSRIs, venlafaxine, and SNRI. This is for sustaining serotonin levels and regulating norepinephrine, which is the fight or flight. And it is also used to reduce the manifestations of anxiety. And PRN medications include beta blockers and benzodiazepines. Though in severe cases, both of these may be prescribed daily, and are used to also ease the symptoms of like sweating, rapid heartbeat, or shortness of breath. which would also help them to reduce the sense of anxiety. And one thing with the prescription of benzodiazepine is that it has a risk of dependence. So make sure that in patients' education that they are informed of this risk, and they should also be tapered off the medications, as well as routinely checked in with the physician for access, for right dosage, and its effectiveness for that person. What should you do as a nurse when patient is on benzodiazepines? A. Take vitals routinely. B. Educate patient for risk of dependence. C. Make sure that patient is tapered off the medication. D. All of the above.
Along with medications to treat acute stress disorder, there are also psychological and behavioral interventions that may be used. Debriefing is one intervention that may help. This is usually 1 to 2 sessions of therapy, which includes psychoeducation for the patient. They also learn coping skills to help with the symptoms. They are advised to avoid media coverage if the media is involved in their traumatic event. Patients also discuss their cognitive distortions that they may have developed, and the therapist or nurse may explain signs and symptoms. Another intervention that can be used is a school intervention if the patient had experienced the traumatic event in a school setting. Cognitive and behavior therapy may be another intervention used for a patient with acute stress disorder. A question is, what principles should you consider as a nurse when speaking to a patient with acute stress disorder? Please choose all that apply. A. Reduce stress. B. Ensure that survivors have a safe environment. C. Help patients reframe destructive cognitions. And D. Promote coping mechanisms.